Hi, my name is Aaron Gerds. I'm the editor-in-chief of ASH Clinical News, and we are here on site in sunny Orlando, Florida to cover the ASH annual meeting. And I'm absolutely delighted to be joined by Dr. Gabby Hobbs from Mass General, a world-renowned expert in MPNs. Thank you for joining me, Gabby.
My pleasure.
All right, so one of the kind of headliner, if you will, abstracts for MPNs this year was the presentation of a ongoing clinical trial, a phase 1 clinical trial with a monoclonal antibody directed against mutant calreticulin protein. Of course, this was a plenary session several years ago at this very meeting, but now it's kind of come to life through these clinical trials. And so could you tell our audience why targeting this particular mutant protein with this antibody why are we seeing efficacy? Why would we even do this?
Yeah, so really exciting, and I think it's nice that you mentioned the plenary several years ago. It's great to see how drugs can go from that preclinical development into clinical practice. I mean, I think taking from other diseases where monoclonal antibodies are utilized, it makes a lot of sense to target agents that we can target with monoclonal antibodies. For calreticulin specifically, it's a really interesting neoantigen. It's really something that's only expressed in the malignant cells, and so it makes a lot of sense to target it. And hopefully, because of that, we don't have a lot of off-target toxicities. Yeah. And so I think there's been a lot of excitement and waiting to start seeing some of this clinical data.
Yeah, and not only this particular monoclonal antibody, but there are other monoclonal antibodies being developed. There's bispecific antibodies, even cellular therapy. So really an exciting time targeting mutant calreticulin protein. So particularly with this presentation, with this antibody made by Incyte, what were kind of your impressions, when you saw the data, particularly like maybe the toxicity data, and how might we use this drug going forward?
Yeah, so very exciting. I mean, I think we had seen some of the ET data already, so we already knew that this was a well-tolerated agent. And I think they demonstrated for the myelofibrosis cohort that this remains a relatively well-tolerated agent. Now, myelofibrosis, different disease than essential thrombocythemia. So there were two groups, one that received the calreticulin monoclonal antibody by itself and one that received it with ruxolitinib. And the efficacy is definitely there, but I would say that it's more modest than what we see in ET. And I think lots of us are speculating, why is that? And one of the things that I think we need to think about is, therapies with different mechanisms of action may just take longer to work, and so the endpoints may need to be different. And I think a lot about immunotherapy when it was developed for solid tumors. Initially disease looked like it maybe got worse and then it got better. So I think we have a lot to learn before we say, oh, this is too modest, maybe it's not going to work in MF. So I still think that it's an agent that really does have a lot of promise.
Yeah, and I draw a lot of parallels to rituximab, right? So rituximab, when it came out as a single agent, kind of modest activity in certain lymphomas, but when you combine it with chemotherapy, it really kind of shone brightly. And you can envision a future with like doublets or triplets even, we're talking triplets, wow, for myelofibrosis, which would be pretty amazing step forward.
Yeah, absolutely. And when you think about lymphoma and R-CHOP, you could not imagine giving R-CHOP without the rituximab. Yeah. And so I think that that's definitely true for myelofibrosis. It's a much more complex, heterogeneous disease, genetically speaking also, so we probably need perhaps more than one medication. But targeting that molecule, I think, really makes a lot of sense.
Well, fantastic. No, it's an exciting development in the field. Again, like you said, really neat to see like a plenary session move into the clinics and now being available for patients. Absolutely. A really great story here at the ASH annual meeting. And you can read about this abstract and all of our on-site coverage in ASH Clinical News.